us. Today is my great privilege to welcome Dr. Lisa Winston and Dr. Grace Hazer. Dr. Winston is a professor of medicine, as well as the Associate Chief Medical Officer for Medical Surgical Services and the Hospital Epidemiologist here at San Francisco General. Dr. Hazer is an ID Fellow at UCSF and also a primary care provider at Ward 86. Today, they are both going to share a report back from IDWeek and give us pearls as HIV providers, both in ID and HIV. So welcome them, and thank you so much both for being here.
Hi, everyone. So delighted to be here. I have the pure ID part of this talk, and there is a lot. So I'm going to go ahead and get started. I believe we're going to save questions for the end. And I just want to say that whatever else we talk about today, we need to save enough time for Grace to get through all of her slides, because the very best picture is on the last slide. Okay, so our first abstract, and if I have time, I'm going to go through 8 abstracts today, is the comparative evaluation of low versus high doses of rifampin for the treatment of staphylococcal bone and joint infections. And this is actually a really important question. So we essentially always use rifampin for staphylococcal infections with hardware. There's some debate about how important it is without hardware, but there actually really have not been any studies on the dosing. And there are a lot of questions about the toxicity. So this study looked at both the efficacy and the relationship between rifampin dose and side effects. Quite a large study in adults at 16 sites in France. So they randomized over 500 patients, and their results were reported both for the intention to treat population and for the per protocol population for this study. So just a few things to point out. Most of these patients were, kind of in the middle ages, with the mean age being late 50s to early 60s, more men than women. About half the patients had orthopedic devices or hardware in place. And for our purposes, that's the group that we are the most concerned about. However, I will say, at least for this presentation, they did not report their efficacy results separately in terms of hardware versus no hardware. Then about 3/4 of the patients had Staph aureus, also the bug that we are most concerned about. And then just to point out, of course, you have to give rifampin with a companion antibiotic, because otherwise you'll develop resistance. And the most common companion was a fluoroquinolone. And that is what we do most commonly also. So I think pretty representative of the patients that we take care of. And those who didn't get a fluoroquinolone got trimsulfa, also a drug we use commonly. What did they find? Both intention to treat and per protocol, success rates were high, did not matter which dose of rifampin you gave. And both serious adverse events and adverse events in general were both linked to the high dose group. So lower dose, better tolerated, and just as effective. And for low dose, for somebody who's 60 kilos, we're talking about something like 600 milligrams daily of rifampin, which is a common dose that we use. This study did not answer the question of, whether BID dosing would be preferred over daily dosing. They used daily dosing, but it was generally well tolerated and effective. So take home, large study, high success rate. No need to push the rifampin dose. I think this is fairly confirmatory of our current practice. Okay, so the next study is a much smaller study, but it is intriguing. So this is preliminary results from a randomized trial of cefixime versus penicillin G for the treatment of early syphilis. This is from Jeff Klausner's group. Also a randomized trial at 12 clinical sites in the US and Peru. in adults. Notably, about 2/3 of the study participants are living with HIV, although in order to be in the study, did need to be on treatment and virologically suppressed. And these were folks who had primary, secondary, or early latent syphilis with an RPR titer of at least 1 to 8. And then, not surprisingly, they excluded neurosyphilis, pregnancy, recent or simultaneous antibiotics, which could confound the outcome, or an allergy to cephalosporins or penicillin. Not always so easy to find the folks that meet these criteria. They screened about 1,200 and enrolled 145. They randomized to cefixime, which is an oral drug, for 10 days. IM penicillin. And then notably, because shortages are a huge problem for treatment of many infections, including syphilis, some of the folks who were randomized to penicillin actually had to get doxycycline, which is the alternative. Note that they lost quite a few folks between randomization and the modified intention to treat because you had to come for at least one follow-up in order to be evaluated for efficacy. So that, is a known challenge. So what did they find? Well, good news, they all work. So cefixime had almost 90% efficacy, penicillin had 90%, and doxycycline in the 7 participants looked great, 100% efficacy. Notably, we might actually have even better efficacy when we get the 9 months of available data, because this is just looking at a serologic outcome. And generally, you have longer than 6 months to see if you get that 4-fold decrease. So I thought this was very encouraging, although the enrollment is modest. There was a high success rate in all groups. Cefixime may be a reasonable alternative if you can't use benzathine penicillin. Doxycycline is a really nice alternative. It works, but this was 10 days instead of 14 days. We always worry about drug shortages. You can have more than one drug shortages at a time. I also worry a little bit. Penicillin has not shown resistance. Syphilis has not shown resistance to either penicillin or doxycycline to date, but you never know. So the more drugs that we know of that work, I think the better. Unfortunately, it's not, another single dose therapy the way penicillin is, but maybe we will get other trials of that. Okay. So then the next study to go over, and this is a really actually quite impressive large study, is 7 versus 14 days of antibiotic treatment for patients with bloodstream infections. You notice that the IDWeek folks put it in their practice-changing abstract session. And I think that's fair. I think this is one of those studies that could change practice for a lot of people. And I think the authors appropriately put out that, figuring out the correct antibiotic duration is important. We don't want to treat too short. We might get clinical failure or relapse, but we definitely don't want to treat for too long. We get more adverse events, including issues of resistance. And then they also point out that in many studies, when you look at contributors to unnecessary days of antibiotic use, that the most important contributor is excessive durations. So definitely something we would like to know more about so we can get to the Goldilocks duration that is just right. So this study was done in 74 hospitals in 7 countries, a very impressive undertaking coordinated by clinical trials groups in Canada and Australia and New Zealand. These patients were adults who were in the hospital when the blood culture was reported positive. But as you'll see on the next slide, most of them had community-acquired infections. You had to have a pathogenic bacteria, so if you just had coag-negative staph that was thought to be a skin contaminant, you weren't included. But notably, Staph aureus and Candida were excluded. So we will need other studies, and there are some out there that are accruing, thinking about what the appropriate durations and types of antibiotics are for these infections. They had a number of other exclusion criteria, including prosthetic heart valves. severe immunocompromised, which they actually did not define in their presentation. So I look forward to seeing that when the study is published, or if per the investigators' criteria, the patient was thought to have a well-defined requirement for prolonged treatment. So some subjectivity there. And it was randomized and open label. So they assessed more than 36,000 folks for eligibility, and notably, a little over a third were eligible. So I think this is something that we will have to keep in mind when we think about 7 versus 14 days is, who met the eligibility criteria. But a lot of people did meet the eligibility criteria. So here are the infection characteristics. Notably, about 3/4 were community onset. And these were pretty sick patients. So 55% of patients were enrolled when they were in the ICU. So severity of illness is not exclusionary. And you can see the top 11 pathogens here. A lot of them are gram-negative Enterobacterales. Not surprisingly, given the patient population, E. coli is right at the top. So what did this study show? Well, pretty robust primary outcome of 90-day mortality, and it was the same. And the secondary outcomes were also the same. No real concerns about any safety events. I will note, I think one of the things we'd be most concerned about is relapse of bacteremia. And although there were a tiny bit more in the 7-day arm, it's only 0.4 percentage points because this is a large study, which was not statistically significant. So really looks quite good. And I think the take home is large study, robust results against many organisms and, different infection sources. But just we need to keep in mind the exclusion criteria. And I think we will do this. We already do this, but I think we will do it even more. But we need to just keep in mind who would have been eligible for this trial and try to get more data for people who wouldn't have been. Okay. Keeping on going. So another very high profile abstract was the Shea featured oral abstract of the INSPIRE trial. So this is a 92 hospital cluster randomized study looking at whether we can improve real-time empiric antibiotic selection. And this abstract focused on abdominal infections. And notably, as the authors point out, our current practice is that in many cases, we start broad because we're worried and then narrow. But we might actually do very well, especially if we consider the risks that our patients have of drug-resistant organisms, to start narrow and to broaden if needed. And I just want to point out that although this trial that I'm going to present focuses specifically on abdominal infections, it's part of a quartet. And the results from the pneumonia and UTI trials have already been published in JAMA. And the pneumonia trial showed a 28% reduction in extended spectrum antibiotic use, pretty impressive. UTI showed 17.4%. And then the skin and soft tissue infections results were also reported at IDWeek in a different oral abstract session and showed a 28% reduction in extended spectrum antibiotic use. And they all use the same methodology in the same healthcare setting. So where did this take place? This took place at HCA Healthcare, the largest private hospital system in the US. And conveniently, the authors provided us with some background data looking back at 2017 to 2019. And they, looking at their own data, saw that only 2% of patients with abdominal infections had a multi-drug resistant organism, but 63% received an extended spectrum antibiotic. So a big mismatch there between antibiotic choice and the microbiology. So you're going to see in a minute the picture of what the Meditech EHR looks like, because that's the one they use. Vivek described it as looking a bit like, a 1990s video game. So we'll see what you all think of it. But in any case, at the hospital level, They were randomized to either standard of care stewardship at the hospital or a bundle intervention that gave you a prompt with patient-specific resistant organism risk, a specific recommendation for which antibiotic to use, and then notably, this also included feedback reports by local study champions. And this was designed as a 12-month baseline, 5-month phase-in, and then a 12-month intervention period. Notably, patients in the ICU were excluded, and they were looking at antibiotics in the first 3 days of admission. As a best practice, the provider had to enter the indication for antibiotics, and the prompts were activated when extended spectrum antibiotics were ordered for abdominal infections outside the ICU. They did a lot of modeling, and these were the elements they included that predicted an absolute risk greater than 10%. So this is what the prompt looks like. So if you ordered, for example, vancomycin for an abdominal infection, the prompt would tell you that your patient-specific risk was really low, and they would recommend specific antibiotics, in this case, ceftriaxone, plus or minus metronidazole. And then you would have to do something. If you were going to override it, you would have to put in the reason you were putting in vancomycin. You could easily change your order to ceftriaxone, or you could return to the order screen. So how did this work? It worked pretty well. They had a 20% reduction in days of vancomycin, a 39% reduction in the days of anti-pseudomonal therapy, and a 35% reduction in days of extended spectrum therapy overall. Pretty impressive, with no differences in the safety parameters that they looked at. So take home is real-time patient-specific recommendations can substantially change antibiotic choices. Now we just have to figure out how we can do it here with EPIC. You know, this was a huge undertaking with lots and lots of resources, but I actually think we might be able to do something, although it might need to be a little bit simpler. So I think we'll all be discussing it, but impressive proof of principle. Okay. IDWeek has turned out to be a fantastic venue for talking about vaccines. I think many of you know how much I love vaccines. So I'm just going to go through a few vaccine abstracts here. So the first one was effectiveness of adjuvanted influenza vaccine versus high dose vaccine for influenza, preventing influenza in adults greater than or equal to 65. And just want to point out that this was done by the Kaiser Permanente Research Group, which is an outstanding vaccine research group right in our backyard. And this really is an important question because this is a super common vaccine, and adults 65 and older are all recommended to either get a higher dose influenza vaccine or adjuvanted vaccine. And actually, it's never been studied head to head, which one is better. So this study is a 2-season study, and the results are for the first season, but it's evaluating the relative vaccine effectiveness for adjuvanted vaccine versus high-dose vaccine. And they did a really nice job randomizing all of their facilities to use the adjuvanted vaccine versus the high-dose vaccine on an alternating weekly basis. So they just switched them out every week, which one each site was using. So they managed to vaccinate 212,000, almost 213,000 with the adjuvanted vaccine, as opposed to almost 217,000 with high dose. Really pretty impressive. They tested over 22,000 people in each vaccine group for influenza, and it looked exactly the same in terms of its ability to prevent influenza. So really, I think very robust results here. They also looked at hospital or ED PCR confirmed influenza, no difference, and hospitalization for all-cause community-acquired pneumonia, no difference. So, you know, this will not change practice, but I think is a very nice confirmation that, you know, we could use better influenza vaccines, but of the ones we have, these two, which are very commonly used, no reason to prefer either one. So confirming our current practice. Okay. So how about effectiveness of the updated monovalent COVID-19 vaccines? And this is a CDC study from the Vision Network. So this is last year's COVID-19 vaccine. And just to keep in mind that, these studies now look really different from the original vaccine studies because those were done at a time when nobody had any vaccine-induced immunity, natural immunity was a lot lower, and the risk of getting COVID was a lot higher. So, they just point out that it really is important to keep going with these vaccine effectiveness studies and that we need to interpret them in our current context. So this study was done, as many vaccine studies are, as a test negative analysis. So people who presented to a participating emergency department or urgent care with COVID-like illness were either placed in the case group if they had a positive test, or in the control group if they had a negative test for COVID and also a negative and no positive test for influenza. And the reason for excluding folks who had a positive test for influenza is because there can be confounding by behavior in terms of seeking out vaccination. And then they had robust data from electronic health records, state and city registries as to whether people had been vaccinated. So how well did last year's COVID vaccine work? Well, it wasn't bad up to 2 months after getting the vaccine, about 50% effective. Not surprising, not dissimilar from what we see with the influenza vaccine. I think one of the things we should keep in mind is that it actually had 0% effectiveness once you got out to 4 months after receiving the vaccine. So there was waning immunity. Of course, the overall risks of getting COVID are lower and the risks of hospitalization were lower. There was a more prolonged effectiveness against hospitalization, so still about 23% effectiveness out to 6 months after getting the vaccine. So I think we can, let our patients know that COVID vaccination is effective against both COVID-19 associated illness and hospitalization, but effectiveness does wane. And I'll show on the next slide how the CDC has interpreted this in terms of recommendations for revaccination. I will also point out that one of the main problems, we were talking about this before we started, is in some ways not the science around vaccination, but, our messaging. And, people may be aware that the MMWR just reported that amongst healthcare workers who work at acute care hospitals, only 15%, 1/5, got last year's COVID vaccine. It was even less in skilled nursing facilities where the patients are even more impacted. It was only 10%. So, messaging is tough, especially, when you need these subtleties in terms of vaccine effectiveness. But this is just a slide from the presentation around the context for interpreting the effectiveness, with patients who have a very high degree of immunity. And I put at the bottom the CDC recommendations for this season that people who are 65 and older and people who have moderate or severe immunocompromise are recommended now, and this is a change, to receive 2 doses of the COVID vaccine separated by 6 months usually, but a minimum of 2 months. And that for people with immunocompromise with shared decision-making, additional doses can be given to prevent the issues of waning immunity. Okay. So another vaccine study here. So this also got a lot of buzz as the IDSA featured oral abstract. And this is kind of a complicated study. So I'm going to go through it a little bit superficially and try to get to, kind of the key takeaways. So this study enrolled patients who both had an Mpox vaccination with the Jynneos vaccine or who had Mpox infection. And then they looked at a variety of immunogenicity assays, and they compared people whether they had a history of smallpox vaccination, if they were vaccinated with Jynneos, what the route of vaccination was, the interval between the 2 doses, and the HIV status. And the slides that I'm going to show do not include the patients who had Mpox infection specifically. They include the folks who got vaccinated. So just at a high level, what did this show? Well, it did show that your titers in terms of your immunity did continue to decrease at 2 years post-vaccination in those who were smallpox vaccine naive. In other words, having received prior smallpox vaccination really did seem to be significant in terms of keeping up your immunity to the Mpox vaccine. Even more dramatically, when you look at the difference between the tan bars and the blue bars, if you were smallpox naive and you got Jynneos, you did have a substantially lower avidity to the 2 immunodominant surface proteins that they looked for immunity to. So what is the significance of this? Well, I think it's really important that this is being studied. This does not mean that Jynneos is not effective. We have other clinical studies that suggest that Jynneos has actually been very effective in terms of both preventing Mpox in the short term and in those who have breakthrough infection in terms of decreasing severity of disease. But I think the implications are that we may not have long-term immunity and booster doses may need to be considered. And so I think that's a really important thing to think about. And then also, as the authors point out, Jynneos may not be the perfect vaccine and new vaccines should be studied to see what kind of immunity can be developed. Okay. The very last study that I'm going to present, and I'm going to do this one super briefly. I think this was the one that probably made everyone the saddest. It was done in the very large ballroom with a large crowd of folks, and this was tecovirimat or TPOXX for the treatment of Mpox in the Democratic Republic of Congo, the DRC, or the PALM study. And notably, only clade 1 of Mpox is circulating in the DRC. So they randomized people, mostly children, to get either tecovirimat or placebo who had Mpox. All these folks were hospitalized for 14 days and had really robust monitoring in terms of swabbing their lesions and looking for resolution. So they assigned about 300 to get tecovirimat and about 300 to get placebo, and it was done at 2 sites in the DRC, Tunda and Kole. Very sadly, the primary outcome was negative, as were the other outcomes. So there was no statistically significant difference in time to lesion resolution between intervention and placebo. And I think people were quite surprised because, as we were talking about yesterday, the animal data for this were very robust, but for some reason, this did not seem to extend to patients in the DRC with clade 1 Mpox. So the synthesis is, big study, 64% children, quite a high lesion burden, no safety concerns, but no reduction in the duration, no differences in virologic outcome. There were some subgroup analyses that suggested that there may be a treatment effect via site for the different sites, but this was actually very unclear, and there wasn't, good reasons to explain it. So this was a eagerly awaited but negative study, and now we're waiting for STOMP results. And we're not going to take questions now, but if people do have questions about this, I'm glad to try to answer them. And Annie Luchtmeyer is here, and she can probably also answer questions. But moving on to Grace.
Okay. All right. So changing gears, going to talk about some of the HIV topics that were presented at IDWeek. And if I can summarize kind of the major theme of the HIV data that was presented, there was a lot of stuff on long acting, both for treatment and for PrEP. And that is really what I'm going to focus on today. So first, one thing that got a lot of buzz was the results of Purpose 1 and 2 were presented, and the results of these have sort of been trickling in, but they were kind of nicely summarized. So I'm just going to go through that here. So as some background, Purpose 1 and 2 were both randomized controlled trials looking at use of lenacapavir for HIV prevention. Purpose 1 enrolled cisgender women and girls in South Africa and Uganda. Purpose 2 enrolled gay and bisexual MSM, transgender women, transgender men, and gender non-binary individuals. Around the world, there were sites in North and South America and Sub-Saharan Africa and in Asia. And the study design was pretty similar between the two. I have the Purpose 1 study design here. So just to kind of orient us, first, the investigators did this kind of cross-sectional incidence, which I thought was really a nice kind of clean way to evaluate the background incidence of HIV in the population. So at the time of screening, they obviously screened everybody for HIV and then determined if they were HIV positive or negative. And that was sort of what they used as their metric of the baseline background incidence. So for those that screened negative and were eligible, they were randomized in Purpose 1, 2 to 2 to 1 to one of 3 arms, every 6-month lenacapavir, daily TAF or daily FTDF, which was also interesting because, you know, we don't have a lot of data on FTAF in cisgender women, so they kind of evaluated that here. Purpose 2 had a really similar design, except participants were randomized 2 to 1 lenacapavir or FTDF. I don't know why this looks like this. Okay. So for some reason, there's some weird widget thing happening with the slides here, but I can try to summarize. The baseline characteristics for Purpose 1, you can't see it here, but it was a very young cohort. The median age was about 21. It was almost 100% Black race, given where they enrolled participants. And there was a pretty high rate of STIs amongst at screening. I think it was like 25% of participants had chlamydia, and very low rates of prior PrEP in the Purpose 1 cohort. Although most participants had actually been screened for HIV at least at some point in time. In Purpose 2, the age was a little older. I think the median age was about 28. And it was more racially diverse, which kind of fits with where the study took place. Also, a decently high rate of baseline STIs and a much higher use of prior PrEP. I think it was maybe a quarter of participants had been on PrEP at some point in time, and similar rates of HIV screening. And then to get into the results, they were very encouraging. So again, to orient us, looking at Purpose 1 and Purpose 2, the first line is kind of that baseline incidence that they got from screening. And then they looked at seroconversions in each of the arms. And we can see that in Purpose 1, there were 0 seroconversions, which was highly, highly encouraging. And in Purpose 2, there were 2 seroconversions. Also still very encouraging compared to the baseline incidence. They didn't really present anything about those 2 seroconversions, so look forward to kind of further presentations in the paper to kind of learn about who those patients were. But also interestingly, we can see that unsurprisingly, oral PrEP did have some efficacy, but it was much more effective in Purpose 2 than it was in Purpose 1. They did collect drug levels in these participants, which I don't have a slide on that, but we did see that in Purpose 2, tenofovir levels for people that were randomized to the tenofovir arm were much higher than they were in the Purpose 1 cohort, which is kind of fitting with prior oral PrEP studies in cisgender women. It seems that the adherence to oral PrEP is lower in that population. And then in terms of their analysis, they found that lenacapavir was 100% effective in reducing HIV infection in Purpose 1 and 89% in Purpose 2. And they also found superiority of lenacapavir to oral PrEP in both arms. They did not find a statistically significant difference in efficacy of FTAF or FTDF in Purpose 1. Notably in Purpose 1, and this was a study of very young women, and pregnancies were quite common, and they did not exclude people who became pregnant. They allowed them to remain on study, and they collected pregnancy outcomes, and they were very encouraging. There were no meaningful outcomes in pregnancy, which is great to kind of get some information there too. And then they also collected information about injection site reactions. So they were common, particularly nodules, but we can see that injection site reactions decreased over time. I did want to point out that pain was much more common as a reported side effect in Purpose 2 than in Purpose 1. And I don't know if there's a biological reason for that or if men are just wimpier than women, but I thought that was kind of interesting how different it was. So some takeaways from Purpose 1 and Purpose 2, lenacapavir was found to be superior for PrEP in people of all genders. There was good safety data in pregnancy. Injection site reactions common, as we know, from our use of lenacapavir for HIV treatment, but decrease over time. So sticking with lenacapavir, I'm going to move to treatment. So they presented the 3-year results of the Capella study. So as some background, Capella is a phase 2/3 single-arm trial of lenacapavir with an optimized background regimen in highly treatment-experienced persons with HIV who have multi-drug resistance. They had previously reported really favorable outcomes in this group with 82% suppression at week 104, and here they presented the week 156 data. Again, I don't know why this is happening, but I see. Okay. So we're gonna fix it for next time. Sounds good. That's okay. So as you can see from these widgets, but just to give you a little bit of background on the study design. So these were all patients who were failing an ART regimen. Cohort 1 was patients who had a baseline HIV RNA greater than 400 copies, and then cohort 2 had less than 400 copies. And then within cohort 1, they were randomized to start oral lenacapavir or just continue with their background regimen for the first 14 days, and then kind of put everyone on subcutaneous lenacapavir. And kind of looking at, we're really mostly interested in the 104 to 156 data. So these are all patients on subcutaneous lenacapavir with an optimized background regimen. And then in terms of some of the background and kind of the study participants. So this was mostly men. And in terms of kind of HIV parameters, there was, these were patients who were all viremic, but there was a good proportion, like 20% had a viral load greater than 100,000 and very low CD4 counts on average. Most patients had less T cells less than 200, and even almost a quarter were less than 50. And this just lists the kind of baseline resistance. So pretty much all participants had resistance, and almost 50% had resistance mutations to all 4 major drug classes. And then in terms of the virologic outcomes, this is, you can't see on this graph, but these are all in the 80s, like 81 to 84% suppression at the different endpoints. So it was very encouraging to see that the viral suppression rate was about the same between 104 and 156 weeks, although notably there were a large number of participants where they didn't really have data. So this is no additional confirmed virologic failure, but there is some data that's missing there. One thing I'll just note is that there has been sort of a signal for lenacapavir and increasing CD4 count. Again, about a quarter of these participants has CD4s less than 50. We can see that over time, these participants have rising CD4s with fewer and fewer with AIDS. And some of that is possibly, just now being suppressed and being on treatment, but, it has been hypothesized that perhaps there is a mechanism that we don't understand of lenacapavir sort of with the immune system. This is just kind of observational, so no mechanism was proposed. And then in terms of resistance, there were 14 participants overall in this cohort who developed lenacapavir resistance mutations, and they determined that all of those were patients who either had no fully active agents in their optimized background regimen or were not adherent. And a number of those patients were actually able to suppress with or without a change to their optimized background regimen. Notably, between 104 and 156 weeks, there were no additional failures, and there were no additional resistance mutations detected in the cohort. So some takeaways, we already knew that lenacapavir with an optimized background regimen is a great tool for patients with multi-drug resistance and multi-class resistance. But now we know that it's also durable with kind of continued suppression over time out to 3 years. And maybe there is some signal for kind of helping with patients with very low T cells to kind of bring those back up. Okay, so now I want to talk a little bit about kind of the ART pipeline, both for treatment and prevention. I'm going to start with talking about, this is all for treatment, but there was some data presented on long-acting oral ART. So I'm going to get into that a little bit. This is a slide that I stole from one of the IDWeek presenters, looking at just kind of an overview of the ART pipeline. And I think this is just kind of exciting to see that we have new classes of drugs, we have new kind of formulations of drugs, and hopefully a lot of things kind of coming down the pipeline that will give our patients more options. So I will just summarize briefly the week 40 results of a study looking at once weekly oral islatravir plus lenacapavir. So as we know, lenacapavir is a first-in-class capsid inhibitor. Islatravir is an NRTTI, so also a new drug class. They both have very long half-lives and kind of multiple different mechanisms of action, and which allows for weekly dosing and also potentially some options for patients who have resistance to other drug classes. So this was a phase 2 open label switch study comparing weekly islatravir and lenacapavir to daily Big-TAF FTC. And they had previously reported their 24-week data, which was encouraging. So this was an update at 48 weeks. So to get into a little bit about their methods, the eligibility criteria were quite stringent. Participants had to be suppressed on Big-TAF FTC for at least 6 months. They could have no history of urologic failure, and they also had to have CD4 counts above 350. So quite narrow, but they randomized these patients to either continue on Big-TAF FTC or switch to weekly islatravir lenacapavir. And then a primary endpoint was proportion with HIV greater than 50 copies. In terms of their baseline demographic information, the median age was 40. It was a largely male cohort, pretty racially diverse, and we can see CD4 counts were quite high because they were required to be from the inclusion criteria. And the outcomes were really encouraging. So there was over 90% suppression below 50 copies in both arms. And there were notably no cases of confirmed failures. The only other cases were patients who either didn't have data or kind of had dropped out of the study, and they noted that no one had dropped out because of treatment-related issues. It was sort of like other reasons that patients had discontinued the study drugs. In terms of the adverse events, both drugs were well tolerated. There were no significant like grade 3 or grade 4 adverse events that were reported related to the study drug, although notably there were more adverse events reported in the islatravir lenacapavir arm in general. They also looked at laboratory data, and there was no significant difference in CBC. Notably, so part of the reason why why the CD4 count criteria were so high is that there had been prior data reporting kind of a drop in CD4 count with islatravir, which they felt was not as big of a risk with this particular dose of islatravir, but that was part of it. There was no significant difference in CD4 count, and laboratory data was really the same amongst both arms. I will note, though, that there was one participant in the islatravir lenacapavir arm who developed acute hepatitis B infection. So as just a reminder that these drugs do not cover for hepatitis B, and so making sure that there's appropriate screening, vaccination for these patients and coverage for these patients is important. And then just very briefly, kind of more in the pipeline of long-acting oral drugs. This was a multiple ascending dose phase 1A study looking at this new drug GS-1720, which is a weekly oral INSTI. And they had previously reported good data that would support weekly dosing. And this was randomizing patients without HIV into various doses. They looked at weekly and daily dosing, and overall essentially supported weekly dosing. So that kind of brings us to some of this kind of weekly oral pipeline. So GS-1720 and GS-4182, which is a prodrug of lenacapavir. And weekly, we are studying that now, looking at weekly dosing. There are a couple of other drugs in the pipeline, and they sort of mentioned in the sort of ART pipeline talk that there's this new third generation INSTI that has long-acting potential that's in the pipeline. So it is exciting. So some takeaways, there are likely some new weekly oral ART options that are in the pipeline. For me, it's not entirely clear to me exactly which patients are going to benefit from this and who will prefer this. I think we need more information about just sort of patient preferences and who these drugs are really going to be for, but it's always good to have options. Having more options is better than none. So this is some of the new ART that will be coming down. Okay, and then I'm going to talk a little bit about some outcomes of long-acting injectables in the real world, both for treatment and for PrEP that were presented. So first, there was an oral presentation on the use of long-acting cabotegravir rilpivirine in patients with adherence challenges coming from UCSD. And they reported their outcomes there. So they defined patients with, this was a retrospective chart review. They defined patients with adherence challenges as either having poor response to oral ART, as defined by having multiple viral loads greater than 200, or being lost to follow-up with greater than 6 months between visits without any contact and being off ART for at least a week. And they looked at sort of a composite outcome of treatment discontinuation or virologic failure. In terms of the patients who were kind of in this study, in this clinic, it was mostly white non-Hispanic men. I don't have that slide here, but that was sort of the dominant patient population. There were high rates of active substance use, namely methamphetamines, and also high rates of mental health issues. And so looking at the results, they reported the 24 and 48-week results for their clinic. So at 24 weeks, they had 12 patients who either had virologic failure or who had discontinued. So it was about an 81% virologic suppression rate, and it was 50-50. So there were 6 patients who had virologic failure, who had detectable viral loads, and 6 who had discontinued cabotegravir rilpivirine. Of the 6 that had virologic failure, 3 had cabotegravir rilpivirine mutations. The other 3 did not, and actually were able to resuppress on cab rilpivirine. They didn't really present too much of the data in terms of like the timing of when those patients got injections and things like that. They also, in terms of the patients that had discontinued, 3 of them were lost to follow-up, which was a little bit disheartening. At 48 weeks, they really found kind of the same virologic suppression rate. So it was still 81.5. It was 81% suppression rate of the patients who continued on Cabro. And unfortunately, and kind of dishearteningly for me, there were still 5 additional patients who had virologic failure. They didn't present data on if those patients had failed with resistance or exactly what happened with those folks, but a little bit discouraging to kind of see this drop off. However, maintained a suppression rate in most patients. They did a multiple logistic regression as well, looking at multiple factors, and the only statistically significant factors of virologic failure were low CD4 count and active substance use. So in terms of kind of my takeaways from this report, I think this is in the growing real world literature about, support of Latitude. And we have a lot of data from Ward 86 about using long-acting injectables in folks that have adherence challenges. So that is encouraging. I was a little bit discouraged to see that they had like ongoing virologic failures, but overall kind of similar results to what was found in Latitude. And I think really just notes that the main thing that we need to kind of work on is how can we help support patients who have active substance use to help them stay on therapy, not get lost to follow-up, and not have virologic failure. And then I'll just quickly run through a couple of studies looking at long-acting cabotegravir for PrEP, now that has also been rolled out in the real world. So there were 2 presented. The first one that I'll talk about is from the OPERA study, which is this very, very large cohort study. They found, I believe, like 740 something individuals who were on cabotegravir for PrEP. And I don't have my notes here, but I'd say some of the big takeaways in general was that it was effective. There were only 2 seroconversions that they noted, and actually on adjudication, they felt that those patients did not have cabotegravir coverage at the time of their seroconversion. So overall, there were good results in terms of lack of seroconversion. They also had in terms of on-time injections, about 1/3 of patients did have a delayed injection, but the vast majority of patients who had a delayed injection got their next injection within a week of their target. So overall, decent job with on-time injections. Where there was kind of concerning results was in kind of just the operations of HIV screening. So about 1/3 of patients did not get an HIV test within a week of starting cabotegravir for PrEP. And then there were an additional like 11% of patients who never had follow-up HIV screening while they were on it. And only 50% always had HIV screening. So that was a little bit concerning. Then they also presented data from the TRIO cohort, which is an EMR-based research database of 12 clinics, also very large. They had 526 patients who were on cabotegravir for PrEP, really just 474, though, who had gotten at least 2 doses, and that's who they kind of looked at. And this is sort of a busy slide, but sort of summary is that they had very similar results to OPERA in terms of lack of seroconversions, and on-time injections were decent. But similarly, I just wanted to point out that there were also a number of patients who did not get appropriate HIV screening as they persisted on cabotegravir. So kind of some takeaways is that cabotegravir seems to be very effective in the real world setting for PrEP, which is great, but definitely more work needs to be done kind of at the clinic level to ensure that patients are getting on-time injections and appropriate HIV screening. Okay, and then here are my references. And here's the website.
Thank you so much, Dr. Winston, Dr. Hazer. We're going to start with questions from anybody in the audience. All right, let's do.
This is for Lisa from the INSPIRE trial. Did they mention this is an EMR prompt to help with antibiotic choice? Was it only for the primary teams, or was there any talk about how like ID teams that were involved and how they handled that? I was just curious about that.
Yeah, great question. So they didn't mention, and it's very helpful. You can get a lot of details about the INSPIRE trial because 2 of them have been published in JAMA. So it was whatever provider was putting in the order would get it. So I don't think there was any distinction between who was ordering it, but they didn't talk about what the ordering patterns were at the HCA hospitals. And it's possible, since it was 92 hospitals, that they had some differences in who was doing the ordering.
Those were such great presentations. I have two questions. One for Grace about the injection site reactions in Purpose 2, both nodules and pain, and if there were discontinuations, because that wasn't presented. I couldn't hear that. I didn't see that in the press release from Gilead, obviously. And then the second is for Lisa about tecovirimat, and do you really think there could be a clade-specific effect of that medication, or you think that there was supportive care provided in the trial for both arms, and maybe that did reduce the fatality rate above what clade 1B usually results in that region?
I don't believe they reported on the treatment discontinuations. I'll have to double check, but I don't think they reported that.
You showed us higher in Purpose 2.
It was higher in Purpose 2 than in Purpose 1. The serious adverse reactions were not noticeably different between the two. They were very rare, but injection site reactions in general were higher in Purpose 2 than Purpose 1. At least pain was. I think nodules were just kind of common in both arms.
Yeah, Monica, great question about tecovirimat, in the DRC for clade 1 and whether it might be clade specific, and also about the low mortality rate. So I think, and would love to get Annie's thoughts on this as well, but I think it was really good that there was a very low mortality rate, which may have had a lot to do with the fact that all these patients were hospitalized for at least 2 weeks and got in-hospital care. But there wasn't any difference whether you got tecovirimat or not. So I think they did, kind of optimize the environment of care, but they didn't see any signal. And then whether you would expect there to be a difference by clade in terms of how tecovirimat works, I don't think we have a biologic reason to think we're going to have a difference by clade. But there are a lot of differences in terms of the types of patients who got infected in the environments. But I think based on the data we have, we aren't really expecting different clade specific results. Annie?
Yeah, I agree. I have this on. Is it on? But the primary endpoint wouldn't have been affected, because the primary endpoint was time to clinical resolution, right? And so that wouldn't be affected by being hospitalized. I mean, maybe you'd get better care in both arms, but the primary endpoint wasn't mortality, which thankfully was low, but that also was likely reduced there. So I think we'll really look forward to STOMP. And as you said, Lisa, also background immunity might play a role here too, which we think will be much higher in the STOMP group, and we'll have to see both for vaccinations and prior exposure. So whether that matters, I don't know.
A question online is for Grace. What are you taking away from Purpose 1 with regards to the use of Descovy in cisgender women? Has this changed your practice?
Yeah, that's a great question, because as you could see, the results were not particularly encouraging in terms of the efficacy of just both oral arms in cisgender women. That being said, I think it most likely that's, an adherence issue. And so I think I would still, if I had a patient who still preferred to be on oral PrEP and really did not want injections, I would still offer it to them. I would probably, I think kind of for all patients, I'm very encouraged by these results when lenacapavir becomes available for PrEP, to offer it to them as sort of my first offer. But I think giving patients lots of options is always best.
take one comment from online. Dr. Christopoulos shares that via Lucas Hill's PharmD at UCSD, their viral suppression rate at 48 weeks, and this is with regards to sort of real world follow-up of Latitude. 4-week viral suppression, including alternate ART, was 89%, slightly lower but comparable to the 92% that Matt Hickey recently published in CID related to WAR-D6's Cabral outcomes. Correct. So you including use of alternate ART and then suppressed.
Yeah, they sort of presented, they were only presenting the data on suppression for patients that were on injectables, but there were patients who switched to oral ART, and it sounds like they did better. They were able to achieve virologic suppression in those patients with oral ART as opposed to injectable. It's so interesting if it makes you want to be on oral ART, but here to oral ART better. Starting on IM. That's amazing.
Lisa, this is for you, and I don't know if you've read the JAMA paper. So it kind of is not surprising to me if you tell people not to use broad spectrum, they don't use them and will use less broad spectrum. But I just, like as a clinician, I just want to make sure all the clinical outcomes and endpoints were okay. And were those in the JAMA papers? And
yeah, so there's a great question, Diane. There's a lot more information in the JAMA papers, not surprisingly. So all of the outcomes they looked at, there were no differences. So there wasn't a safety signal. That being said, they didn't look at every possible safety signal, but I think they looked at the most common ones. And perhaps it wasn't that surprising, just given how few people actually had the organisms that people were kind of targeting with the antibiotics. So I think that they were actually pretty judicious in what they recommended, and probably smart. They said, if you're in the ICU, if you're really sick, maybe those are the people you don't want to invert the pyramid, and maybe you do want to start broad and then narrow because the consequences could be more significant.
Thank you both so much. Let's give them a round of applause.
Amazing. Yay. Sorry about that. Yeah. So essentially, it's like the computer didn't think about those.
Thank you.
So we're very sorry. Your slides look good. We'll fix it for next time. But it wasn't every. Yeah. We should like hearing that.